Now I request Dr. Shreesh Kumar to speak on risk like IOL implantation in special situations.
Thank you, Dr. Satyamurthy, for the opportunity. And my talk is a continuation of Deepak's talk. It was nice videos, Deepak. So nicely have demonstrated the procedure. So it makes easy for me to continue with my talk. Any indication for iris clip IOL is a special situation, and any compromised capsular support or any complicated surgery with the compromised capsular support is an indication for iris claw lens implantation. And I'm just going to show a few videos. This is actually a regular case of iris clip IOL. It's an aphakic eye, and I'm just creating a two side port paracentesis exactly 180 degrees away from each other, and I'm just swiping with the iris spatula to see whether there is any tags of vitreous in the pupillary area, and then placing the iris clip lens. This is the holding forceps which I use. This is actually a broad-based forceps, which is slightly different from what Deepak had shown. So this IOL stabilizing forceps, and I usually hold it at the junction of haptic and optic, not exactly in the center, which Deepak had shown. It gives a good grip, and I use a Sinsky hook. Of course, I don't pull it, and then. This is the picture, the post-operative picture. This is what you want to have. This is a pinch. There is a dimple on the iris. This suggests there is adequate enclavation that has happened. This is another special situation where you can see it. I was actually planning to do a phacoemulsification with the capsular hooks, and then CTR I thought of implanting. So I was making some side port incisions for introducing my capsular hook. But surprisingly, I didn't realize that it is such a advanced zonular dehiscence. After injecting fluid into the anterior chamber, I realized that there's hardly any support. You can see there is tilting of the lens. The tilting of the lens, and if you see the sorry. So the support is only here. This is 1 clock hour of support here, and there are another 2 clock hours. So it is actually tilting. This axis is the fulcrum, and the lens is tilting. So there is hardly any support. It's a hard cataract. Then I thought of proceeding with the ICC. I removed the lens in toto and enlarged the incision. I made a sclerocorneal incision, tunnel incision in the same site. So hardly 3 clock hours of support, 1 clock hour in one axis and the 2 clock hours in the other end. So then the routine procedure of iris clip IOL implantation is done. And the procedure is quick. It hardly takes 10 minutes for us to complete this procedure. It's not like scleral fixated IOL. In our hands, it takes at least 20 minutes. This is another situation where it's an aphakic bullous keratopathy. It's a chronic case of aphakic bullous keratopathy. You can see the opacification of the cornea also and the thickened epithelium. And you do anterior vitrectomy, and you need some support for the tamponading effect of the air bubble when you are introducing a lenticule into the anterior chamber. So for that, the iris clip IOL implantation definitely helps. It gives us support from behind, and the air won't escape into the vitreous cavity. So this is one special situation wherein we can do a iris clip IOL implantation. I just want to show that what happens if you are injecting air into a aphakic eye without any support. So it won't stay in the antechamber. So it's like it escapes into the vitreous cavity, and even through the side, the iridectomy site also it is going into the vitreous cavity. So it's a difficult situation. Either you should have a SFIOL. SFIOL, usually there will be a gap between the pupillary margin and the lens. So iris clip IOL works very well in these cases. It's very difficult to maintain a tamponading effect. So invariably you end up having a dislocation of the lenticule which you have implanted. So as another case, here there is a large sector iridectomy iris defect which is extending from 2 o'clock position to 10 o'clock position, 10 to 2 o'clock position, and I'm just suturing the pupillary margin. There is a McCannell's kind of procedure which I am doing, and so you have a pupil kind of shape in the pupillary area, and then you can introduce your lens, and of course it's a little difficult. Sometimes you may break the suture which you have placed, but it actually helps. And the iridotomy which you have here is of course covered under the iris, so the patient will not have much symptoms. This is how it is post-operatively. This is another case of traumatic cataract where I was not sure about the status of the posterior capsule. Anterior capsule is broken because I could see the cortex in the antechamber. And like any other traumatic cataract with the anterior capsular rupture, went ahead and did the cataract extraction. This is actually a very soft cataract. It doesn't require any phacoemulsification. It's just a phacoaspiration and irrigation and aspiration. But to my surprise, there is a tear in the posterior capsule also, and it's a large tear in the posterior capsule. Anterior capsule is already gone. Only I have some tags here, the capsular tags here and here. I could have gone ahead and placed a lens in this axis, but it is risky. I am not sure about the support here inferiorly and superiorly. So in such cases, iris clip IOL comes in handy, and just takes another additional 5 minutes for the lens to be placed. This is another case of complicated cataract situation where the surgeon was doing a phacoemulsification. It's a small pupil, and there is a zonular dialysis and anterior and posterior capsular rupture. So this is a situation wherein there is no point in preserving this capsule. You can do anterior vitrectomy and go ahead with the iris clip IOL. And there is a dislocated bag with the IOL. It's a severe PXF case. Again, you have to, it's difficult to reposition this. This is actually 5.25 millimeter phaco profile lens, which PMMA lens, which we used to implant many years, like 2 decades back. Now, of course, I don't think this kind of lenses are available. It's actually a phaco profile lens, which has overall length of around 12 millimeters. So you have to just explant this and place a iris clip IOL. Here again a case of complicated cataract, and there is hardly any PC support in this particular area. There is support here. I thought we can place a lens PC IOL, but there is no support here at all. While retracting the pupil, I could see a ECR, that's endocapsular ring, CTR. You can just wheel it out and remove the capsular remnants and place iris clip lens. So I have 1 minute. So this is another case. The surgeon has operated thinking that the lens is in place, but next morning when he saw it is actually decentered. So there is hardly any capsular support. You need to remove this and either place iris clip lens or do SF5 implantation. This is again a case of subluxation. The patient had injury. It's a case of iris clip IOL in situ, but in one area it is slightly decentered. It was holding on to the pigments on the back side of the iris in one particular area, and this needs re-enclavation, and there is vitreous pushing the lens inferiorly. Inferior, that's nasal, towards nasally, and you need to do a vitrectomy and then re-enclave it. This is the last case. This is again a case of iris clip IOL implantation, but the lens was hanging. It was attached to the iris in one side, but the other side there is no enclavation. You have to just go behind this mark, that is where the iris clip is pinching the iris, and then you bring it to the pupillary plane and tuck it. So it's you have to be very careful. You can just fish it out in the open vitreous, but you have to go just below the iris where it is enclaved, and then you can bring it to the pupillary plane and reposition it. So any complicated cataract surgery with compromised capsule is a special situation, and the iris claw lens comes in handy in these situations. Thank you very much. Actually, it is as we actually compared it with our vitreoretinal colleagues do SFIOL, and anti-segment surgeons we do iris clip IOL implantation. It's almost the same. There is hardly any difference as far as the CME incidence and the recurrent UATs and all is concerned. It's a compromised situation, complicated surgery. The overall outcome may be less compared to the regular cases, but as such, there is hardly any difference between SFIOL and iris clip IOL implantation in our cases.
Thank you.
The meta-analysis that I referred to in this year's last
Yeah.
had a high incidence of CMA with
Iris clip, okay. Maybe. Yeah, no, it works very well in our hands. Most of the cases we do, anti-segment surgeons prefer this in our setup.
No.
The idea of going behind the inclination on one side and the other side has got dislocated.
Yeah.
It's a very good idea.
Yes, yeah.
Going particular going and
Yeah, it's just to go behind there is a dimple mark, just go behind it and you just pull it.
only the vitrectomy is right.
Yes, yes. Usually after vitrectomy only we do this, yeah.
I mean,
Yeah, total vitrectomy, yeah.
No, one question to both Dr. Shreesha and Deepak. your experience in pediatric age group, iris because iris is very hyperreactive in pediatric.
Yeah. Again, of course, the inflammation part, it's much more aggressive in case of pediatric age group. But we have not seen any unusual complications in a pediatric age group. In a case it is mainly a traumatic cataract and progressive subluxated cases, we try to preserve the capsule and try to place a PCIOL, but it's only the traumatic cataract where there is no support for anterior and posterior capsular support is not there. Such cases only we try this iris clip IOL implantation. Not found anything different from adult cases.
Dr. Deepak?
Yeah, I have got limited experience. I got two patients, one with microspirophakia and other with Marfan's. The age would be somewhere around between 12 years, one patient, and another 14 years. Follow-up is around 4 years until now. So far, so good, sir. Not any major issue. But until
No,
now.
only problem is that iris atrophy and later on the
It
iris
is,
lens can
it
get dislocated.
that's a possibility. But as for the inflammation, my experience is very limited. So I can talk only about these 3 or 4 eyes, that's all.
Yes, thank you. Thank you, Dr. Shreesha Kumar.